Okay, so we're going to open it up to your questions in just a minute, but we didn't think it was fair to just say, okay, you have any questions without at least getting a patient perspective on the multidisciplinary team from somebody you all know and love and who's been through management from a disciplinary point of view and knows what some of her questions were going through it. So I'm going to introduce someone who probably needs no introduction in this group, Jan Narutami Hart, who is just a force of nature as concerns the advocacy, the support, the fundraising for worthy causes like caring for carcinoid. One of the first people I met when I took this job, and I knew I had made the right decision. And Jan, of course, for those of you who were with us last year, won the Monica Warner Award for that outstanding kind of leadership and advocacy. And she's going to just talk a little bit from a patient perspective, and then we're going to come back and throw it open to all of your questions for the rest of the hour of our team. So welcome, Jan.
Hi, I guess I don't need to tell you my name, so I'll go on from there. And indulge me for those of you who have heard my story, but I promise that it will lead to the topic of what I was given to talk about, the perspective. I especially want to thank Caring for Carcinoid and the Cedars-Sinai Medical Center for hosting this great educational seminar for us every year. And for that, we're eternally grateful, because patient education and awareness is, of course, the ultimate where we want to go with learning more about our own disease. For those of you who are here for the first time or newly diagnosed, I just want to give you a special welcome, and please continue to stay in touch and be in touch with some of our support groups. And also, those of you who have heard my story, just indulge me for a few minutes while I give a little background before I talk about why I feel it's important to have a multidisciplinary team. I was diagnosed in December of 2003 with metastatic pancreatic neuroendocrine carcinoma. Fortunately, kind of by mistake, it was a car accident about a year prior to my diagnosis, and it was the car accident wasn't my fault, by the way, but the trauma ER docs did a CT without contrast, and good thing, because I am allergic to the contrast that they used to have. And it showed that I had a mass in my abdomen, and so my primary followed me for a year with the regular tests that were given, which of course turned out to be normal. So a year later, when my conscientious primary doctor decided to order a CT with contrast because I had some flu-like symptoms, which were probably unrelated to my NETs, she was floored, because then I showed a huge pancreatic mass, and it had already metastasized to my liver with innumerable liver mets. So at that time, I live in San Diego. At that time, I was deemed inoperable by two esteemed medical centers, and was scheduled for chemotherapy and radiation, the traditional kind, because they kind of lumped me in the pancreatic adenocarcinoma group. And being net naive at that time, I had no clue that that treatment might not have worked for me. But something in my gut, and there's no pun intended here, made me jump into action, searching the internet like most of us do, since I just wanted the tumors to be out of my body. I had no idea what they were. I just wanted them gone, and I thought I'd go on with life as normal right after that. Well, that wasn't what was going to happen, but fortunately, I found a carcinoid conference the next month up in Glendale, and so I drove up here and attended it as a naive newbie, and of course, I felt like a stranger in a strange land, like some of you probably feel today. I had no clue what everyone was talking about, all these acronyms like CGA, 5-HIAA, serotonin, Ki-67, and I thought, oh my God, this is too much. What am I in for now? I also did get on the carcinoid websites, and which listed all the neuroendocrine specialists across the country and around the world. And so, of course, I was thrilled when I saw that there was a neuroendocrine center right here in Los Angeles at Cedars-Sinai. So in order for me to come here, I had to fight to switch my insurance from an HMO to a PPO so that I could obtain all the necessary scans that were ordered, the specific labs, and also to see the NET specialists that I felt were needed to make a more definitive diagnosis and to get my treatment plan going. So I started my healing journey in 2004 right here at Cedars. And I'm here to say that that decision was probably the best one that I've ever made to save my life. The NET team here currently in place has grown, as was mentioned before, and as time has gone by and due to the increased rates of NET diagnosis, which I feel is due to better education of the medical professionals and the patients, and teaching their doctors too, their regular physicians, and the awareness by foundations like the Caring for Carcinoid and others around the country. I think that it now includes so many more neuroendocrine specialists, thanks to Dr. Wolin and his team, that we have such a great working effort to try and help all of us with this rare disease. Sorry, I kind of lost my place here. But knowing that it gives me a sense of security, knowing that I'm followed by specialists who work together, meet weekly and monthly, they share information, and they discuss our individual treatment plans, and then they communicate that to us. So I feel that despite having excellent local doctors, I'm still in San Diego, my primary doctor, I also have a local oncologist who works when needed with Dr. Wolin. I have cardiologists, pulmonologists, another gastroenterologist down south just in case, and all the other ologists or whatever else I need to see. And they handle all my other medical issues close by. But the NET team communicates fully when needed with all of those involved in my overall care. And for these reasons, I feel confident that I continue being as healthy as I am or seem to be, and living with this incurable but manageable and treatable cancer. And with an amazingly extraordinary quality of life, which is important to all of us. Since I've been dealing with NET cancer now for over 8 years, I want to leave you with a few wise words of wisdom, I think, from my experiences. And I think the doctors have mentioned it before, but no matter where you go for your treatment, hopefully it's with a neuroendocrine team, we, with our rare disease, must stay vigilant. We have to be our own proactive advocate, or at least have somebody in your family or in your corner helping you maneuver through the sometimes complicated medical systems, bureaucracy, and the insurance red tape, especially when you're not well or you don't have the energy to do it for yourself. So even if you have stable disease or NED, no evidence of disease, continue to live your life fully and enjoy it. But don't let your guard down. Keep up on your follow-up appointments, your scans, and stay proactive always. And just remember to spread the word and raise the awareness, which is something that Caring for Carcinoid helps us do, for neuroendocrine, so that we can help bring in donations to fund research for a cure, which is the mission of Caring for Carcinoid. So thank you very much.
Okay, so we're going to, it's 4:10. We have the room till 5. We're going to throw it open to you. I just want to mention, for those of you who are newly diagnosed, if you're not involved with one of the patient groups in the area, Jan Narutami Hart, we're in the San Diego area. Is Giovanna still in the room? Where are you, Giovanna? Giovanna Mbisi, more for the greater LA area, yes? Redondo Beach, Pat Gerende, just raise your hand, Pat. And any or all of them would love to speak with you, get you involved. They work well together, and we are thrilled to be able to work with them. So what I'm going to do, and I'm going to ask for about 5 minutes at the end, we're going to get to your questions now. I'm going to ask Dr. Wolin to maybe come up and manage, or just do it from down there, whichever you prefer. Why don't we come on up to the microphones? Any and all questions are fair game for any of our speakers, or if you'd like to hear more about a topic that was discussed this morning, and you had that question that you didn't get to ask, now's a great time to do it. So come on up to the microphones.
Hi. I guess this is for Dr. Wolin. We heard about what a great drug everolimus is, and if it's causing... Dr. Wolin, we love the drug everolimus, but if it's causing kidney issues. Would a reduction in that, would that kidney function come back, or is that something that could cause permanent, kidney damage?
Everolimus normally can be used safely even if people have some mild impairment in kidney function. It can interfere with kidney function, but if the impairment is mild and you take a break in the medication and the kidney function is stable, it's possible to use a low dose. It's hard to say in this format here, in this setting, about the optimal recommendations in this particular case, but I could tell you that this is a medicine that is very unusual. You can have lung toxicity, which for other drugs you would say, forget it if you're getting scarring in your lungs, but with this medication you can reduce the dose and that will subside, and people can go for years and years taking it at a low dose, even though they can't tolerate it all at a high dose. And the same thing for kidney toxicity, but if somebody's having problems with kidney function, it needs to be very closely monitored by the physician.
But it may return with a discontinuation or a reduction in dosage?
Yeah, it's
Okay.
appropriate. Are there other questions?
Yes. I wasn't going to go to the microphone because I'm loud anyway.
Okay. Speak up.
Dr. Yu, you mentioned diabetes and pellagra.
I did not mention pellagra per se, but I did mention diabetes.
Okay. I didn't have diabetes before carcinoid. After being on serotonin for almost 2 years, I developed diabetes. Is that common?
Okay. Okay, sure. Yeah. So it is pretty common to develop diabetes after you're diagnosed and especially treated for your carcinoid or the other neuroendocrine tumors. So one of the major cause of this increased risk of diabetes is the treatment. In specifically sandostatin. Because sandostatin does increase the risk of diabetes. So if you do not have diabetes before, you can develop a mild or even sometimes severe diabetes after you are treated. But if you have a baseline diabetes before you are diagnosed with carcinoma or other neuroendocrine tumors, the treatment of sandostatin can make the diabetes worse. But it's very worthwhile to continue the sandostatin. I do not mean to tell you that sandostatin is a dangerous drug. It is a great drug, but it does have some side effects. But we can manage the side effect very satisfactorily, so you do not have to worry about the long-term safety of sandostatin.
I just wanted to make one more comment about the question that was raised about pellagra. Pellagra is one of the rare complications of carcinoid syndrome, but I could tell you that every case of pellagra I have ever seen in my life has been in somebody with severe carcinoid syndrome. And what happens is that you use up the tryptophan, as Dr. Strauss was talking about, and when you don't have enough tryptophan to make serotonin in the brain sometimes, you also don't have enough tryptophan to make niacin, which is a very important vitamin. And if you don't have niacin, you can get a very severe disease known as pellagra that comes from niacin deficiency. And the problem is that the name pellagra comes from the Italian meaning ugly skin. The reason that the skin is called ugly is because it's all red. And this is happening in people who already have severe flushing from carcinoid syndrome, some people even developing rosacea and other complications from severe carcinoid syndrome. So it can sometimes fool doctors who aren't familiar with it. It's actually different than a carcinoid flush because the redness is associated with very thick, sort of scaly skin, and the redness stays for prolonged periods over the whole body. It's not like a flush. And it can also be associated with psychiatric problems and severe diarrhea. And the severe diarrhea can also be mistaken for carcinoid syndrome. And really the only treatment for this is to supplement niacin or lots of tryptophan. You have to make up for the deficiency. So it's recommended that people who have carcinoid syndrome with significant flushing and diarrhea make sure that they eat a high protein diet so there's a good dietary source of tryptophan, and to use some non-flush niacin supplementation, because otherwise if you take too much niacin too quickly, you'll flush, and then you're really going to get mixed up. I don't know if the psychiatrists want to speak more about the psychiatric manifestations.
No, you did great.
Thank you. Any other questions?
Yeah, I got a whole bunch, but I'm going to try to limit it. I can ask these because my mom just went to go get her MRI and her CT. So this is good because she would just be embarrassed. All right, because these are questions she really wants answers to. A lot of them are, okay, gas and diarrhea, obviously a really big issue. And we've been trying for a long time to manage it. And she can't find any patterns in what she eats, but also she has, since her Whipple surgery, has had a really hard time keeping on weight. But she eats like crap because, you know, if she eats like vegetables from her garden, it runs right through her body. But if it's like, you know, if she eats like potatoes and cheese, she might keep a little more in her system, right? So as her family, we're very concerned about this woman who is eating nothing but like potatoes and ice cream because it's been happening pretty much for like years now. You know, like she had her surgery, what, in like 2009? So as her family, one, potatoes don't make you feel like you want to go exercise. We can't get her to exercise. Two, you know, she can't keep the weight on, so it kind of gives her an excuse to eat like crap, and it is every woman's dream to have Dr. Wolin say, I hear there's a 2,500 calorie shake at, you know, at Cold Stone, but you're killing us, Wolin, because we can't get vegetables in this woman. So yeah, so it's really like the food, the gas, that stuff related, and then so it's kind of like a two-parter, and it's for all you guys probably answer all this stuff. But I just recently found out that actually Cedars does have like a program for patients that you can reach out and find like a therapist here, which is something we did not have at all. And we live, you know, she lives 4 hours away from here, so she's not going to come down to therapy. Depression has been a really big issue, and it doesn't matter how positive we are, right? Everybody knows when you're depressed, they got to pull themselves out of it. So depression medication. How are we going to make her feel more comfortable about her gas and diarrhea and getting better food in her body? And then I guess just like therapy, you know, when somebody's that proud and they feel like a therapist is like a negative thing, can we get them on happy-go-lucky drugs?
Okay, thank you very much. So maybe we'll start with diarrhea and junk food comments from Dr. Medizadeh, and then we'll talk about the psychiatric aspects and rehabilitation aspects.
Can you hear me? So I think you touched on really multiple issues. I mean, this is about an hour answer when we sit down with you brought up a lot of issues. So diarrhea is quite complex in carcinoid. It can have many reasons. It can be because of Octreotide treatment, because it can suppress pancreas, so something we call exocrine pancreatic insufficiency. So the enzymes in the pancreas are needed to digest the food, and when that food is not digested, it hangs out in the bowel, and the bacteria can eat it, so it can actually cause gas, bloating. It can be something kind of similar to lactose intolerant, except it's any food intolerance because you don't have the enzymes amylase, lipase, protease from the pancreas breaking it down. You also mentioned Whipple in your comments. So Whipple is a procedure that part of the pancreas is removed. So that's another reason to have, for example, pancreatic insufficiency and not digest food, get gas, bloating, diarrhea. What also happens is when you don't digest the food, mainly fats. Fats are the main nutrient that will not get digested when the pancreas is not working well. And fats are the most calorie-rich nutrients, so you can't gain weight and you're losing a lot of calories. You mentioned fruits and vegetables, so sometimes fruits and vegetables are the most sort of gas-producing items. They're just frankly harder to digest. We think about things like a hamburger being really hard to digest. It is. It takes longer to digest hamburger, but it's really absorbable. It disappears, almost all of it. Not much of it makes down to the colon, but something like broccoli is really, it just doesn't get absorbed. So it really goes through the entire 15 feet of small bowel, and it has a chance to meet a lot of bacteria and get fermented and produce gas. So sometimes eating healthier can produce a little bit more symptoms. I don't know what other points that you...
I love that you went over that stuff, but we know why. We completely understand why it's happening. What I would like to know is, should we be concerned that she is not consuming any foods that are really good for her at all for years at a time? Like, you know,
Just make a quick comment.
yeah.
Okay, so just a quick comment, and I'd be interested to hear what everybody in the panel feels. There's a difference between what's healthy for you and what is healthy for somebody who has carcinoid syndrome. What's healthy for somebody who has carcinoid syndrome is that every day you have enough calories and enough protein that you don't break down your muscles, you don't lose weight, you don't become debilitated, you don't weaken your immune system. Okay, and if you can't digest vegetables properly, you can treat your acute and chronic vegetable deficiency by making vegetable juice and drinking it without all the fiber. There are ways of still eating a healthy diet. You could take a vitamin pill. There are a lot of ways of still maintaining health that are different than what a normal, average, otherwise healthy American should be doing to maintain health, which is to eat lots of veggies and drink lots of water. If you're suffering from malnutrition as a result of cancer, you may be better drinking high-calorie, high-protein liquids and eating things that have less fiber if you can't handle the fiber. So that, I think that you have to kind of individualize, and that's why it's very important to talk to dietitians, to talk to gastroenterologists, and other specialists who can help with this. So I'm interested to hear what other people.
Can I add a few words? Sure. I completely agree with Dr. Wallen. Every patient is different, especially when you have a rare disease such as carcinoma or pancreatic neuroendocrine tumor. So if you go to a regular doctor who sees the garden variety of common diseases, they often tell you something that is actually not right. For example, if you have 70% of pancreas, resected, as part of a surgery, then you are treated with sandostatin. You really have a high risk of developing diabetes. But this diabetes is not because you are a couch potato or eat too much. It's because you don't have a functional pancreas, and the remaining ones are inhibited by the sandostatin. But if you go to a regular diabetes educator, usually it's a woman, she's going to tell you, oh, you should not eat that, should not eat this, and because they use often well-rehearsed words, right to most of our Americans, but wrong as for you. For example, I have a patient with a really bad malabsorption, and she does have a mild, diabetes. Then she was told by her dietitian that she should not eat any ice cream, should not eat, fat, but she has a poor, malabsorption. I told her that all the junk food that are bad for other people probably is good for you now. I mean, any weight is good weight, because nutrition is the most important thing for you. And we should not put the cart in front of the horse, So I really suggest that that if you have you or your loved ones when you have this rare disease and complications associated with this kind of disease, you should really talk to someone who actually know about the disease rather than going to just a general practitioner, because there's a lot of nuances and niceties that we need to pay attention to.
Right. Would Dr. Strauss and Dr. Escher like to comment on the psychiatric and rehabilitation components of the question?
Well, I can say just briefly, and you may know this already, but one of the wonderful things about this cancer center, even in this era of diminishing resources, is that there are still mental health professionals employed to work in the cancer center. So there's a psychiatrist and a team of social workers available to your mom through Dr. Wolin, and he can arrange for her to have a psychiatric evaluation to answer the question whether she'd benefit from antidepressants, and also sort of gently visit that area of what kind of counseling she might be willing and able to participate in.
Well, I have to say that I've been coming to the groups with Jan and Giovanna put together, they're amazing. But I think what happens here is sometimes the carcinoid patients miss that step. And they don't realize that it's something that's available to them because they're not going through the chemo side of the office
Yes.
where those people are. So I just found out about it, but we've been coming here since like 2009. So, but that's great.
Yeah.
Okay. Next question.
Hi, I'm a newly diagnosed carcinoid patient, and although Dr. Fisher said that it wasn't going to talk about the lungs, well, that's where mine is, but I'm not going to talk about the lungs. I want to talk about the whole body, okay? Recently, I was diagnosed in July of 2011, and I have multiple nodules. My question is, through all the testing, the MRIs, the CT, the PET scans, nothing lights up. They can't find the primary carcinoid. In the meantime, I'm experiencing symptoms, different things going on. I want to know about the serotonin also, because I understand it affects sleep, concentration, other things that's going on in the body. And so I asked the doctors questions about, you know, well, are you sure that I have carcinoid? And they say, yeah, the biopsy, you know, says it, but they're doing all of these tests and, you know, they can't find anything. But in the meantime, I keep a lot of infections, and when I go into the office and I tell them certain things that are going on with me, like fatigue, tiredness, lack of energy, and I'm usually an energetic person, and they tell me things like diet and exercise, which I know all of that, but I do also know my body when it changes and certain things that are going on. So if you can, all of you on the panel, I just recently got out of Eisenhower Medical Center the last of March because I went in with shortness of breath and weakness. My voice is still a little raspy, and they treated me with antibiotics and steroids, and that kind of gave me some relief, but it's still a lot of inflammation. It's like deep inside, it's like an infection down in the gut I can't seem to get rid of. So if you can, you know, just talk to me and let me know or give me some guidance, I would appreciate it greatly.
There are many, many issues that you raise, and I think it's going to actually be very hard sorting them out without really knowing all the even more detailed knowledge of your medical history and the results of the x-rays and tests. Just a few general points. One is that one of the manifestations of carcinoid syndrome is wheezing. It is possible to have any kind of carcinoid tumor that's making hormones that can affect lung function. So that's one of the questions. We need to evaluate the hormones in the blood and see if you actually have carcinoid syndrome or you have the wheezing from something else. Carcinoid tumors, neuroendocrine tumors, can start in the lung. Dr. Fisher was talking about more aggressive kinds of lung cancer that he wasn't talking about in this conference, but I'm happy to talk about any neuroendocrine cancer anywhere, and they certainly can start in the lung, but they could also start in the intestine. They could also typically be spread around and nobody knows where the primary site is, because the most common primary site is in the small intestine. And if you don't look for it with the right tests, you don't find it. And at Cedars-Sinai, just for example, we find the primary site about 85% of the time when people don't have a clue where it is after upper GI endoscopy, colonoscopy, CAT scans, and everything. They come here because we do tests that specifically will show where the cancer is. Dr. Medizadeh can talk a little bit about that. Sometimes we never do find the primary cancer, and we just have to treat the disease anyway, and that's okay too. We can treat with the same kinds of treatments that we were talking about, whatever is appropriate, because a lot of the tumor treatments are fairly similar, whether it starts in the lung or the intestine or somewhere else. But sometimes the treatments are more specialized. If you can prove it's definitely from the pancreas, for example, there might be some other treatment options available to you. But you have a lot of things that need to be sorted out. But,
Yes, because I'm not getting any treatment. And so when I was at the oncologist yesterday, I did explain to them I was coming over here and I was going to ask questions, because when I was at Eisenhower Medical Center, they took me in through the emergency. They counted the nodules. You know, I have like 75 on one side, 50 on the other. I want to know why I have so many nodules,
Okay.
and I'm not being treated.
right, so you need to be seen by people that are specialists in this kind of problem, and a multidisciplinary team that can put their efforts together to figure it out. It isn't something that we can necessarily figure out just from a little bit of information today, but I'm trying to give basic principles that might help you and help all the people in the room.
Okay.
Dr. Escher, Dr.
I
Strauss?
think so too. I think so too.
Anything else you want to say? Oh, about endoscopy.
Double bill, maybe.
Okay.
How it affects the sleep, you know, because I get up several times during the night.
I would just say, I don't know how clear I was in my earlier comments, but if your tumor is producing, even if your tumor is producing serotonin in the lungs, that's unlikely to be affecting the sleep mechanisms in your brain because that serotonin doesn't enter the central nervous system. But you've already told us about 6 or 7 other reasons why you might be having sleep difficulty related to the breathing and that sort of thing. Do you want to speak to that?
With regard to the fatigue, I think in many cases when the underlying disease is treated, the fatigue gets better. So I agree with Dr. Wolin that I think you would really benefit from a comprehensive evaluation to try to get the disease under control. If your team feels like it's okay for you to begin some gentle exercise, we talked about keeping it moderate. One way you can do that on your own without getting formally assessed is something simply referred to as the Sing-Talk test. And all that means is if you can't speak in a full sentence when you're doing your exercise, so if you start with something simple like walking, if you can't talk while you're walking, you're going too fast, so you need to slow down.
Yeah, I've experienced that. Okay, all right, thank you.
Thank you. Next question?
Hi, 2 items. The first one, you mentioned wheezing. Does that extend to coughing also? Do some people cough a lot with this situation, or is it just wheezing that a symptom? Does anybody know?
Coughing is certainly part of the situation. If somebody has tightening of their bronchial tubes, it's like having an asthma attack, and you certainly can feel short of breath as well as having a cough. But sometimes there are other factors. Somebody might actually have a tumor involving the chest, and that can be causing direct pressure on a bronchus. The individual cases need to be sorted out. But in general, when you have carcinoid syndrome, and if wheezing is a component, it's often associated with shortness of breath. Thank you.
Shortness of breath. One other question. I noticed Dr. Fisher mentioned that carcinoid tumors of the ileum he said 95% of them are well differentiated. Does that mean that the person can live almost a normal life with a situation like that? What's the circumstance there?
No, it does not mean that. When the tumor is called well differentiated, it means that the proliferation rate, how fast the cells are dividing, can range between 0 and 20%. They are well differentiated tumors can either be grade 1, in which 1 or 2% of the cells are dividing by Ki-67, or it could be grade 2, where 3 to 20% of the cells are dividing. And if you have a cancer with 1% of cells dividing, it's not nearly as fast growing and aggressive as one where 20% are dividing, yet it's all called well differentiated. So it's correct that they're well differentiated, but there are different things within that spectrum.
Within that, it's grade related.
And then the grade could also change over time, and what is a lower grade tumor can become a higher grade tumor, not usually really high grade, but there can be some increase in aggressiveness over time. So it is a little complex. And I don't think anybody has said with any grade that you can necessarily live a longer life, even though some people live totally normal lives. It's still, you have to treat these cancers with a certain amount of respect and make sure that they're being monitored and not growing, because if they do grow, they can cause trouble.
Okay, so monitoring very important. Okay, thank you.
Okay, thank you.
Hi, I have a question about PRRT. Dr. Wolin, you mentioned potential of maybe 40 months without growth, which sounds amazing. But I was just wondering, after that 40 months, if and when growth occurs again, what are possible options, and is a second round of PRRT something to consider, or is there a resistance?
Okay, so these are all good questions. For people who weren't here in the first part, PRRT, peptide receptor radiotherapy, is referring to a technique of using a therapeutic amount of radiation attached to octreotide, injecting it intravenously, letting it find the tumors, attach to the tumors, and nuke them. It's a very effective treatment that's been used in Europe for a long time, and is now, the technology is spreading. And Cedars-Sinai is beginning its program in the next 2 weeks, and we'll be doing that here at Cedars. And unlike the programs in Europe, the one available now is going to be paid for by the manufacturer of the isotope and be free to patients, and which is an enormous help to people. Okay, this kind of treatment is normally only able to be done one time in a lifetime, to have 4 consecutive treatments. Each one has a certain quantity of radiation, and when you get to the point of having 4 treatments, that's about as much as the body can take. If years go by and the tumor comes back, you can potentially do it 2 more times, but you can never do the whole cycle of 4 times again in general. In general, it's not a safe thing to do. The other thing is, when I was showing you that information, the average period of control with no tumor growth is 40 months, but that doesn't mean you expect 40 months. It means it can be anywhere. It can be years and years and years, or in some people it might not work so well. These are statistical averages, and when you're actually a person being treated, it depends on what happens in your particular case. Thank you.
Hi, I have a question. I was diagnosed 3 years ago with small gut carcinoid. Recently had a stomach ulcer, and my serotonin levels have increased, and I'm wondering, I've gotten an ultrasound, a CAT scan, and an Octro scan, but I haven't gotten an MRI. I'm at Kaiser, I don't have a team, and so I'm wondering, is there a protocol that I could present to my oncologist about ordering an MRI? Or is it necessary?
I could tell you that an MRI is not absolutely necessary. A triple phase CAT scan that's done really well can give comparable information. There are many university carcinoid centers around the country that don't do MRIs as much as we do at Cedars. I'm a big fan of MRIs, not only is a really well done MRI with EOVIST contrast able to show tremendous detail, but it uses no radiation at all. And if you're repeating a scan every 3 months in somebody with metastatic disease, the total radiation exposure over years is much less. However, you can get beautiful imaging with a well-done CT. It just needs to be ordered as a triple-phase CT, and somebody needs to make sure that the studies are done optimally.
Okay, also, as far as the stomach ulcer, would that be related to an increase of serotonin in the stomach?
Would you like to talk about stomach ulcers?
Sure.
Isn't that part of carcinoid syndrome or not? That's one of the, that's what's noted.
The stomach ulcers are not part of carcinoid syndrome. Dr. Medizadeh can talk a little bit about that. The syndrome that we think about when somebody has stomach ulcers and a neuroendocrine tumor is a tumor producing gastrin, which is another neuroendocrine hormone, not serotonin, but gastrin. And when tumors make that hormone, it's common to get stomach ulcers. But
So I
those
should get
tumors usually start not in the small intestine, lower down, but they usually start in the duodenum or pancreas area. Did you have any comments, Dr.?
Right, and sometimes characteristically they cause really severe ulcerations. I'm not sure how it looked, or a single ulcer sometimes can have obviously other reasons. It can be any medication used, sometimes can be H. pylori infection, but the serotonin itself, it's not associated, or carcinoid or serotonin is not associated with ulcer. It's, as Ed said, it's the type of tumors we call the Zollinger-Ellison syndrome, or these are the gastrin-producing tumors that really increase, they rev up the amount of acid that's produced, and they usually cause multiple ulcerations and a lot of inflammation.
Okay, so if the CAT scan's negative in the stomach, then or the doctor scan, so I don't need to worry about anything. I shouldn't ask for a gastrin level because I haven't had that. Does that make sense?
Right. I'm sure that they biopsied the ulcer as well, and they also got
They
biopsies.
didn't do anything with my ulcer.
Usually we check for H. pylori. That's one of the probably just speaking in a
think?
wide general population, is probably one of the most common causes of ulcer.
Okay.
And also if you've used any NSAIDs, meaning aspirin, naproxen, ibuprofen, Advil. Also depends. We call ulcer. A lot of times we do endoscopy and we call something an ulcer. It can be a tiny 3-millimeter ulcer, which may not have any consequence. So we do see them often, honestly. But or it can be an ulcer that's a centimeter deep, has a nice crater, and we wonder, whoa, where did this come from? So it also depends on the size and depth and the look of an ulcer. But generally, as a gastroenterologist, one of the first things we do is the 2 most common things are making sure you're not using any non-steroidal antiviral inflammatories, and making sure there's no H. pylori involved. And also depends if it's a very tiny ulcer, we can just treat with acid medications. If it's more extensive ulcerations, then it may warrant some more workup.
Okay.
Yeah,
One more. Oh.
Yeah, about the measurements of gastrin levels, it is not that straightforward in interpreting the gastrin results. Sometimes the gastrin levels can be falsely elevated because you're taking anti-acid treatment. So I would not interpret say an abnormally elevated gastrin level as evidence that you have a gastrinoma. So
Okay.
this all
Okay.
need to be dealt with in a sort of comprehensive way.
Okay. The octreoscan, is it still the protocol where you have to do the clear liquid diet for 4 days and all that?
We don't do it that way, and
Yeah, that's what I'm
and I have
wondering.
not been convinced that it makes any difference.
Okay, is there like a protocol somewhere that I could show? Is there anybody that, having Kaiser is okay, but I feel like I need to be my own advocate. So is there anywhere that says that I could show them that I don't really need to do that, or maybe I just don't do it, right? So you don't have anybody do,
Octreotide scanning is not normally something that we do over and over and over. I completely agree with Dr. Fisher's comments that you only do it when you need it. I do an octreotide scan on newly diagnosed patients, and I do an octreotide scan if I really need that information to
Okay.
plan treatment. But I would not just do it as a means of monitoring cancer, because you can see little cancers as well. There was a remarkable presentation at the American Society of Clinical Oncology in 2010 from Sloan Kettering called Octreotide Scanning in 2010, Do We Still Need It? That was the title. And it turned out that with over 100 patients where octreotide scan was compared with MRI and CT,
Okay.
that there wasn't a single case where they found metastases in somebody's insides on the octreotide scan that was not able to be identified on one of the other tests. So you don't do it over and over and over just looking. The only time they ever found something that wasn't previously appreciated was, for example, in a leg bone or an arm bone or something that was outside of the field, and all of those patients were already known to have other similar metastases, and it didn't change the clinical management to do the octreotide scan. So I would say I would not worry so much about these octreotide scans, even though there are places that do them over and over and over. I would much rather see you get good imaging with MRI or CT.
okay, great, thank you so much.
I have two questions regarding nutrition. First, I want to thank the Caring for Carcinoid Foundation for putting up the link to the video and the PowerPoint on nutrition with NETs. It was the first time in 3 months that I've been looking for something that I found some really good information. The first question is simple. The second one is probably more complex. In the first question, I guess many of us have noticed that fatty foods float on the way out. And yet I hear today and obviously they're not being digested properly, malabsorption, all the rest. So, but yeah, I'm hearing today that that's probably something I should be eating, cheeses, ice cream, things like that. So can you help me understand, a little bit about if I'm experiencing that fatty foods float, is it still helping me to eat fatty foods? The second one is that the PowerPoint and the discussion talks about amines and foods that are high in amines and how those interact with the carcinoid syndrome, and so I haven't heard much on that. I'd love to hear some more.
Okay, why don't we start with Dr. Medizadeh?
I'll take on the first one. Yeah. All right, very good question. So the floating is obviously, that's fat. Usually that's fat malabsorption, and that's fat within the stool. So, and the usual cause of that is pancreatic exocrine insufficiency. So there's not enough pancreatic enzyme to digest the food. And as I mentioned, the most important of the pancreatic enzymes is the lipase, which deals with the fat malabsorptions. And there are few reasons why patients with carcinoid get fat malabsorption. We talked about surgery on pancreas or octreotide as a medication. Basically, the hallmark of treatment is replacing those enzymes, and the pancreatic enzyme replacement therapy, and there are medications out there. So the key is to take these with meals. So oftentimes the problem we as I encounter is patients are either not on them, or the dose is not enough, or they're not taking enough of the medications. So as a rule, you need somewhere around I would say close to 40 to 50,000 units of this is lipase units these medications are measured by the lipase units of medication, about 50,000 lipase units per meal, and somewhere around 20 to 30,000 units per snack. The upper limit is really high on these medications. As far as the upper limit of how much you can take, it's somewhere around, I think for, say, Creana is one of the medications, somewhere around 30 pills a day, and we don't recommend that. But we basically, it's patient dependent. So we adjust it to you and your diet. And someone may need one pill per meal, another person may need 3 or 4. Basically, we adjust it so there's no weight loss, there's no floating stools, and you're absorbing your food.
Right. I completely agree with that, and also just want to make a comment that the pancreatic enzyme supplements that are generally prescribed are enteric coated. That means they dissolve in the small intestine and not in the stomach. However, half of the people that are taking these pills are using antacid medications and don't have acid in their stomach. So what happens is that you take the pills and the stomach is acting like intestine. So right away, the pill gets dissolved in the stomach. When it gets to the small intestine, the enzymes are already being digested by stomach acid, and you don't have them when you need them. So in people that are using antacids, using enteric-coated pills, you could end up in a situation where you need enormous quantities of the medication to do the job. Or if you're lucky enough to find one that's not enteric-coated, that's very nice, but there aren't too many companies making these because there's not a big profit on them these days.
Two comments. One, I guess I'll have to stop taking my Nexium if I can get my doctor to give me pancreatic enzymes, because when I spoke with my oncologist about it, he's more convinced that the Sandostatin is what I should be relying on.
Right. Sandostatin results in enzyme deficiency. It makes pancreatic enzyme deficiency worse. That's one of the side effects of octreotide therapy.
That's why I just saw Andrew.
Yeah,
I'm trying to get over to see
it
you.
inhibits the production of pancreatic digestive enzymes. So when you take octreotide, you need to tremendously increase the amount. You're having problems associated with having a pancreatic resection or pancreatic malignancy, and then on top of that, problems from having decrease in enzyme production as a result of octreotides. You need lots and lots of enzymes, and you should be able to eat whatever you want. And fat should not be a restriction as long as you're taking enough enzymes.
Well, I'm better armed for my next visit with my oncologist. I don't know if you can comment on the amines in foods and the interaction.
Do you want to talk about it? The question is about amines in food being triggers for carcinoid syndrome to make flushing or diarrhea worse. And that is one of the triggers. The so-called tyramine is one of the chemicals which is found in aged cheese and red wine and fermented foods. And if you eat those kind of things, it may be a trigger for carcinoid syndrome to get worse. So if you're somebody who's having these kind of symptoms, you should watch out. On the other hand, if you don't have carcinoid syndrome and you have a neuroendocrine tumor, but you don't have carcinoid syndrome, you can do whatever you want. And even if you have carcinoid syndrome, if this doesn't act as a trigger, you don't have to restrict your diet unnecessarily. But if you find such a thing as a trigger, just eat other things.
Thanks. I'm sorry. I'll do this really fast. I learned more in the last few minutes, which was really important. Dr. Wolin told me to keep my pancreatic enzymes, to keep taking them, because I was kind of sloughing off. But I learned why just now, so thank you. Anyway, Guy, okay, that's the arthritis. I just have a quick question. I'm usually in control of my life. Well, sort of, basically. I've been in business for myself with my husband forever, and run bicycle camps and youth groups and all that. With this disease, and I want to know how prevalent this is. I learned of one other person whose wife told me secretly that he was going through menopause also. Anyway, I say that facetiously. I feel like I'm out of control, truly, and not knowing which way to turn, not being able to control some of the things I'm so used to doing mentally. So I think I'm off, is what I think, and I'm going to find out if carcinoids has a lot to do with that.
Dr. Strauss and Dr. Asher, did you want to address those issues?
I'm not sure how specific it is to carcinoid. I think you're describing the very painful, real experience that many people with catastrophic illness have. Less about the specific illness, more about the impact of that illness on their sense of mastery and ability to be self-determining and always in control, and the stuff that we're all used to being able to do for ourselves. So it sounds, in saying that it's kind of a normal experience, I don't mean to in any way diminish how painful or upsetting or disorganizing it is. And I mean, it's part of the existential challenge of dealing with catastrophic illness. So I would say a good therapist or a good clergy person could probably really help you cope with that. But it doesn't mean you're crazy. I hope you know that I'm saying that. Of course, of course. Well, it's not dumb, it's profound. I don't think what she's describing, which is the total impact on your life of this illness as a medication effect. That's my bias. Right, but you know, of course, you're not looking for an excuse. You want to be able to do all those things, and it's just that this is a big one. Do you want to add anything to it?
I mean,
I want to say, like, the fact that you just didn't use the word Everest, like, I honestly, this is, as soon as my mom started taking Cinostat and all these drugs, that sort of happened, even though months and months and months prior, she already had the disease. Years prior, she already had a disease, right? She had it for like 9 years. And I think it's also, I think it has something to do with the drug as well. I don't think it's just not enough, I don't know. But I feel like that's a side effect that not a lot of people are talking about, and we thought maybe it was just us, but the more I see more patients, the more I see it.
I was just going to say, you know, we started, and I think UCLA has a similar program, quote-unquote chemo brain program, and I think, I didn't get to go through that slide, but you remember there's all these issues that contribute to this phenomenon. Part of it may be the drugs and some of the agents, but people feel isolated, people have a hard time sleeping, their nutritional issues may change, not being active in the same way they used to be can be playing a role. Some of the medications used for symptom management can be playing a role. So I think the reason why this type of program is working is because, number one, when you put a small group of people together who are going through a similar process and you share that experience together, I think there's something healing that comes out of that. And then the neuropsychologist in the program, you know, spends a lot of time teaching about coping strategies and how to pace yourself and how to achieve a new sense of balance. And I think, you know, learning either one-on-one or in a group session, some of these new strategies can be really useful for this type of situation.
And very special thanks to all of you. I know what Friday night traffic is like in LA, and you're amazing to still be here with us. So, but if we learned anything today, I think it's the importance of having an experienced guide on that journey, the importance of a multidisciplinary team to help you on that journey, the importance of taking note of your body, of your symptoms, of your experiences, and sharing that with your team so you can sort these things through, which obviously some of you are dealing with, and thank you so much for sharing your stories. And I would add the importance of taking care of yourself, taking care of your mental health as well as your physical health, and taking care of each other, including those wonderful caregivers who are here with you today or back at home, or who you are here for in some cases as well. So please connect with each other, connect with your local groups. On your way out, if you can please give us your feedback. Take an envelope if you're so inclined, and please travel safely. And we will be in Stanford on September 20th. And by the way, that nutritionist who somebody was talking about on our website, she'll be with us on that program as well. So come join us again in Stanford. Be well, drive safely. Thank you.